everybody. It's exciting to meet all of you yet again on this topic of evaluation of corneal ulcers. This is a fairly long topic, so I would like to quickly run you through all the fundamentals of management of corneal ulcer and take up questions towards the end. So, yeah. So before we start, as usual, could you please state your position as to the level of expertise that you belong to? While we go through this, the topic is obviously of considerable importance because this is of a significant public health importance, especially so from the developing countries. And the number of new cases are close to 8 million. We have about 65% of ophthalmologists in training in the audience. Ophthalmologists, both practicing and in training. Okay, good. So there is a fair amount of corneal ulcers in the community, with close to 8 million being reported from the Southeast Asian region only. And it is a cause of considerable morbidity, ocular morbidity. It's a significant sight and eye-threatening condition, and it has almost reached epidemic proportions in the developing world. So the next question that I would like to pose to you is, how often do you manage a case of microbial keratitis? While the audience answer this question, there are several learning objectives that we need to understand. That there is the importance of history taking. There are risk factors. Okay, good. So most of us have voted that they have about 0 to 5 cases per month is what they see commonly. So it's quite important to understand the nuances in history taking, evaluating the risk factors of ulcers, understanding the diagnostics involved, documenting the ulcer, using the appropriate color coding when somebody is noting down the ulcer or making a drawing of the ulcer, and of course the management decision tree and outcomes. So as you can see here, there are several clinical scenarios that are available. These the following 5 pictures on your screen right now are typically the ulcers which are kind of pathognomic for one particular variety. It may be fungal, bacterial, viral, or parasitic such as acanthamoeba. So there are several nuances, several important things that as an examiner you should understand about each particular ulcer and try to elicit that history from the patient. For example, this patient had a chronic ulcer of a couple of weeks duration, and there is a margins which are very fuzzy with satellite kind of lesions, and there are some areas of thinning here too, and some trace hypopyon. The adjacent conjunctiva is quiet. So it's important here to elicit a history of diabetes, a history of immunosuppression, any pre-existing steroid use or polypharmacy. This could very well be a fungal keratitis. However, every type of keratitis has its typical, kind of pathognomic signatures. We are going to discuss subsequently what and how each particular type of ulcer looks like. Similarly, this ulcer progressed very rapidly in a matter of about a couple of days to almost a week, which almost melted away most of the cornea. It has a very wet looking appearance. So one needs to be alerted about a possible GNB infection over here, meaning that whether there was any nosocomial infection, whether the patient has immunosuppression, whether this patient was admitted to a hospital and then subsequently there is an ulcer which spread very fulminantly in a matter of days. And it obviously has a wet looking appearance with a very inflamed eye. This is an interesting case of a middle-aged farmer who used to have annual recurrences there was a very mild kind of a edema of the cornea, some scars and ghost vessels. And there are annual recurrences. So annual recurrences with ghost vessels and scars alerts you to take a history of recurrence, how often, and whether it could be of a viral origin. So this is a case of a viral stromal keratitis, and this patient responded dramatically with steroids and antivirals. This patient is again interesting. It's interesting because this is a chronic ulcer, extremely painful, superficial ulcer, and there is no history of contact lens. In fact, in the Southeast Asian region, there is no history of contact lenses for most parasitic ulcers, including acanthamoeba, keratitis. So what is important is a chronic ulcer with a history of injury with mud or soil, and often they are sustained by people who are working in the agricultural sector. And there is a kind of a dry feathery looking kind of a lesion with irregular margins restricted to the anterior 1/3 of the stroma, with a lot of inflammation of the eye and a lot of pain in the eye. And one should also be alert to look towards the peripheral cornea and see whether there are radial keratitis, which are basically inflamed corneal nerves. So this again, tends to ask you leading questions and elicit a history as appropriate, so that you can go one step closer towards the diagnosis and management of such conditions. So this is another interesting case where this patient presented 2 weeks after an uneventful cataract surgery. What we can see here is that the clear corneal phacotunnel has a tunnel infection. There are some kind of membranous lesions in the pupillary area, and there is a hypopia, which is blood admixed. So the vision has dropped down, so one should also ask for antecedent surgery and also about drop in vision, which will alert the clinician about the use of any possible endophthalmitis that might have occurred in these cases. So in a nutshell, every clinical case, including every type of ulcer, would have its typical clinical presentation, and it is important that we elicit the specific history, which will help us making one step closer to the diagnosis and the subsequent management of these cases. So when we summarize the important risk factors, the most important risk factor is trauma or vegetative injury, unsolicited corticosteroid use, polypharmacy or over-the-counter medications, and poor ocular surface, immunocompromised patient, uncontrolled diabetes, and lack of patency of the lacrimal passages, and contact lens use. So an important article that is relevant here is the review of epidemiological features, microbiological diagnosis and outcome of microbial keratitis, the experience of over a decade, published in the Indian Journal of Ophthalmology and available freely for download from our group. This article analyzes the results of close to 2,000 patients, and amongst the risk factors, trauma was found to be most important predisposing risk factor in fungal and parasitic keratitis, followed by bacterial keratitis. And in addition, most of the patients who presented were inappropriately treated or indiscriminately treated. 41% of patients at presentation had an indiscriminate combination therapy at presentation, and less than 50% of patients were actually appropriately treated prior to presentation at a tertiary care center. So here I will just break for a while and take your feedback about, do you have adequate microbiology support for management of corneal infections? Okay. And then maybe you can quickly poll the other question too. Okay, so it's a fair mix. The group is divided almost equally about people who have and do not have the lab support. And could you quickly answer the other question too? So as an ophthalmologist as well as a cornea surgeon, sometimes it is useful to quickly perform a smear examination and then get on with the results, and which will help us quickly manage the corneal ulcer that we are treating. At least it will make us a more rational management and also provide probably a rational way of approaching and ruling out those conditions which are not there and actually specifically targeting the organism in question. So we have quite a bit of colleagues who are not very comfortable, or rather you can say that you have not initiated into these, but it's actually quite easy. All you have to do is you instill a drop of proparacaine into the affected eye and take a little bit of the sample with a number 15 blade or a heat sterilized spatula. So having taken that, you can put actually one drop of 10% KOH, which can be easily available across any of the labs. And from that, you can actually see whether this sample contains or does not contain fungal filaments. So the traditional microbiology setup for any ophthalmic ocular microbiology service would typically consist of smear examination of 3 particular slides, one of which is the calcofluor white 10% KOH wet mount, the gram and gene sustains, and the culture typically consists of 5% and sheep blood agar, chocolate agar, potato dextrose agar, sabourot dextrose agar, thiol glycate, and brain heart infusion medium. So once you have the inoculate in your lab, you can actually send it across to the microbiologist. In the absence of any of them, you can simply do a smear examination over a lab, available lab microscope, and get on with your results. So we will be discussing in the course of our talk the different clinical scenarios where we will explain and discuss about how to manage ulcers when we do not even have microbiology setup. So that can still put us in a rational way of managing these difficult clinical conditions. Now, it's important here to understand the sensitivity and specificity of these conditions whenever we are interpreting ulcers from the microbiology point of view. Now, if you look at the specificity for the acanthamoeba group of ulcers, it's pretty much in the 90s when a gram is positive for fungus and parasites such as acanthamoeba, which means that it rules in all the ulcers which are caused by fungus and acanthamoeba. And in addition to the other tests that we have, another test of importance is the confocal microscopy. Now, confocal microscopy is something which would typically be available in a research setup. But having said that, it is something which can help us diagnose the bugs in the in vivo or in the live conditions. So, do some of our colleagues have access to confocal microscopy? Okay. So, okay. So quite understandably so, it's something which is very rarely available, but just for kind of an update, confocal microscopy is basically something which is like an applanation tonometry, but it tends to give in vivo live data about the layers of the eye. And as you can see on your screen, this is how it would appear. The anterior stroma would appear much more cellular as compared to the posterior stroma here, which would have much lesser degree of cellularity with oval and wheel-shaped nuclei. The endothelium would be a monolayer of hexagonal or polygonal cells, and the subbasal plexus of nerves would have a reticular appearance. The stromal nerves would appear as thick, straight or branched linear lines. And it's also important to understand that these lines, which are the subbasal plexus nerves, are in the range of 2 to 4 microns, and these are in the range of 10 to 15 microns. Now, why is it important? That when you see, say, acanthamoeba would be about 10 to 15 microns. So you can compare the size of the acanthamoeba cyst to the nerve and say that probably this is acanthamoeba cyst because the size is comparable to that of a nerve. And fungal filaments would be about this thin. That means the thinness of that would be that of the subepithelial plexus of nerve. So it's about 2 to 4 microns. But yes, what we are looking at is probably the fungal filament. Now, how would it look like? So quickly running you through the next couple of slides are that here you can see that this is one of how a fungal filament would look like in confocal microscopy. I'm sorry. So it would look like irregular branching patterns of septate filamentous double-walled fungus. So that would be of the size of 3 to 4 microns, and they would be irregular, they would be in bundles, and they will be branching. And in addition, the bacterial keratitis would have activated keratocytes, meaning that they would be highly reflective and there will be a lot of inflammatory cells. Bacteria typically are not visualized. Acanthamoeba cyst, as I discussed, would appear as round double-walled particles of 10 to 20 microns. You can look at the nerve that is there in the corneal stroma and see whether the gauge of the nerve and the cyst size is same. And typically there is a hexagonal inner wall. Viral keratitis will be characterized by ovoid dendritic cells in the subepithelial layer. So apart from that, it's very important to draw the ulcers in the part of your examination sheet so that it is not only as a way of accurately documenting the ulcer but also as a teaching tool where residents in training can really benefit a lot by appropriately color coding the corneal ulcer and also progressively seeing how the ulcer changes over a period of time. The standard notation that we have here is black for scars and degeneration, blue for edema, brown for pigment, blood will be by red, and fluorescein by green. All the infiltrates can be yellow or orange. So in addition, when there is a suture, you denote by a straight black line and a contact lens by a dashed black line. Edema by blue, and all those areas of Descemet's fold are traditionally denoted by wavy blue lines, and epithelial edema by small circles which are made in blue. Similarly, superficial vessels are traditionally denoted by small wavy branching red lines, and broad straight red lines are stromal vessels. The ghost vessels are of dashed red lines, and anywhere there is lens or vitreous, such as in a corneal tear, then that would be denoted by green. A landmark article on color coding of cornea, which is again freely available, is Waring and colleagues, Archives of Ophthalmology publication. So it's a couple of pages only, and I would strongly urge all of the residents who are in training to go through this article about color coding of the cornea. Okay, so now we'll go to the most interesting section of our talk, which is the management of corneal ulcers. Now, it poses several challenges, especially in developing countries, where the epidemiological patterns are far different than elsewhere. So, we will learn about the rationale of management and early referral. So, we'd like to crystallize our talk into the etiological diagnosis, which is based on examination, the initial treatment when we do not have access to microbiology, the guidelines for referral, and the role for newer antibiotics such as fluoroquinolones, the role of corticosteroids, and the role of newer antifungal agents such as voriconazole. So the best way to make a etiological diagnosis is probably on a good clinical examination, a detailed history, a good slit lamp biomicroscopy examination is crucial. It's important to pay attention to the size of the epithelial defect, the size of the infiltrate, the depth of the infiltrate, the edges, and how does the surrounding cornea look like. And quite obviously, it's important to understand that whether there is any associated thinning or any impending perforation. Now, There are several clinical scenarios here, such as a rapidly progressive disease with a suppurative infiltrate. And it could also be a slowly progressive lesion with a localized infiltrate, as in the clinical pictures there. So each has very different connotations. For example, a rapidly progressive disease with suppurative infiltrates could be of bacterial origin or it could be a mixed origin. And the following group of bacteria like aureus, pneumococcus, pseudomonas and gonorrhea can be fulminant. A slowly progressive lesion alternatively could be more commonly due to fungus or protozoa. However, there are slow growing bacteria too, such as Staphylococcus epidermidis, alpha hemolytic streptococcus, actinomycetes and moraxilla. Gram-positive bacteria typically are very well demarcated lesions. They are localized, the margins are very well defined, and they also tend to progress in a short duration and also tend to respond quite quickly too. And in addition, the gram-negative bacteria tend to cause a lot of melting of the cornea, and there may be quick, rapid deterioration of the clinical picture, which leads to large perforation of the cornea, which may need a therapeutic penetrating keratoplast. And there are certain slow growers, such as moraxilla, as compared to, say, Neisseria gonorrhoeae, which in a very short duration can completely involve the entire cornea, cause a big melt, and that may lead to a complete loss of the eye with extrusion of all the intraocular contents. Nocardia has a very typical appearance, such as a wreath-like pattern, multiple pinhead-like lesions, and a very slow chronic indolent course. Non-tuberculous mycobacteria are typically seen in the setting of the refractive surgery when the LASIK interface is involved by these organisms. But that's too stereotypical. It can also happen without the absence of refractive surgery also, and it can also be a very slow grower. It typically has a cracked windshield kind of appearance. Fungus is typically important in the setting of a warm, humid, tropical climate, and in addition, they tend to grow very slowly. There is often a antecedent history of trauma or vegetative injury, and the persons affected are typically those who are working in the agricultural sector, and the lesion tends to just sit quietly on the cornea, and it appears as a dry, raised, feathery margins with a dry looking infiltrate and very irregular margins, and sometimes the corneal ulcer may have kind of a raised pigmented appearance, kind of a mushroom that is sitting over there. So these are typically caused by dematiaceous fungus, where there is a lot of pigmentation on the area of the corneal ulcer. The pathognomic features of a fungal keratitis would be a dry looking lesion which is sitting on the cornea with very irregular feathery margins, and it would have typically satellites, and it tends to quietly sit for quite a long time with a very chronic course in the eye, and it doesn't respond to any of the treatment, and sometimes it may just progress into the deeper intraocular layers. Another typical ulcer is the acanthamoeba keratitis. Acanthamoeba has resurged yet again with a resurgence seen mostly due to contact lenses in the developed world and due to other factors where contact lens is not very important in the developing countries, where injury with soil or injury with trauma like cattle tail or tail of cows or buffalo hitting the eye, or injury with any innocuous material can actually inoculate this organism, which typically proliferates in the muddy water or in the soil into the cornea. This has a very painful chronic indolent course. It tends to form a ring infiltrate. It tends to have radial keratoneuritis. There is a lot of surface inflammation. There is a lot of limbitis, and it often leads to loss of vision unless appropriate steps are taken to diagnose it and treat it adequately. However, once treated well, the prognosis is good and vision is restored in a large number of cases. So, when we can make so much of sense from the history as well as the classic clinical picture, then why should we need to do an appropriate microbiology? Now, having said that, there are a lot of ulcers which present to the clinician after they have been either treated indiscriminately, treated by somebody who is not having the level of expertise to treat, somebody who is probably a traditional medicine man, or somebody who is just taking treatment from over the counter. So in these cases, whenever there is an indiscriminate polypharmacy, whenever there is some corticosteroids that have been instilled in the treatment of this condition, the clinical picture changes from what is pathognomic to something which can be interpreted as, very, very puzzling. And in these kind of scenarios, it's not really easy to say that what is the appropriate line of management that one should take. For example, take these two cases that are there on the screen now. The ring infiltrate that you can see here can as well belong to a person who has a fungal keratitis, or somebody who has gram-negative bacteria, or somebody who is suffering from acanthamoeba. Now, the treatment is radically different in each of these three possible differentials. So then, microbiology is probably one way in making a rational diagnosis wherever possible. So it is strongly recommended that one should do wherever possible access microbiology, send corneal scrapes, and then go ahead for a management which is based on laboratory workers. So for that, you definitely need a laboratory staff, and there are considerable cost and logistics involved. And most of us in our practice may or may not have access to such a service. So then what do we do next? Do we go for an empirical treatment, or do we strictly follow a microbiology based treatment? Now, we would like to understand that what should one do when microbiology backup is unavailable. There is an excellent source on the internet, which is a WHO document for guidelines for the management of corneal ulcers at primary, secondary, and tertiary levels in the Southeast Asian region. This document is available for free download on the internet. You can refer to it. It very typically identifies those conditions that can be treated at a primary level compared to those that can be treated in the secondary level, and then those which need early referral or urgent referral to tertiary care practice. So, as we were discussing some time back, the specificity of a 10% KOH mount is in the 90s. So, all that you need to start off with is just to do a light microscopic examination. And if you see something like this, where you see double-walled septate filaments which are branching, so probably you are pretty much sure that you are dealing with a case of fungus. And if you are dealing with a non-severe ulcer, then which with very well-defined margin, then it is unlikely to be fungus or acanthamoeba. If it is even smear negative, then also one can start empirical broad spectrum antibiotics and see how the treatment goes. So I would like you to quickly answer this question before we move with the rest of the discussion. Okay, so I believe there is a fair mix of our colleagues who are treating with broad spectrum antibiotics and also with the newer generation fluoroquinolones. Okay. So, in the treatment of bacterial keratitis, either one can use a fluoroquinolone or one can use a aminoglycoside with a fortified cefazolin, which would increase the spectrum until the response is arrived at or until we can get microbiology. Or one can also use the newer generation fluoroquinolones such as moxifloxacin or gatifloxacin. So a non-severe ulcer which has a dry, feathery kind of a margin and which typically clinically looks like fungal, actually one needs to do the microbiology and assess the smear. So if your smear is positive, start treatment with antifungals. If the smear is negative and you strongly suspect that it is fungal and you do not have access to microbiology, it's better to refer the center to a tertiary center. Treatment with antifungals and anti-acanthamoeba drugs must be started only after the organisms have been documented. So, what are the referral guidelines? All severe keratitis must be treated at a tertiary care. All cases which are clinically suspected to be fungal keratitis and where you cannot find fungus in the smear or culture needs to be referred. And where the cases are worsening on empirical therapy, you need to refer these cases. So what is the role of the newer generation drugs, such as the fluoroquinolones, corticosteroids, or voriconazole? So broadly, the gram-positive organisms and gram-negative organisms are susceptible to a wide variety of antibiotics. It is also based on the identification of the organism and its sensitivity profile. Now, whether one should use fortified antibiotics or use commercially available preparations, there are pluses and minuses of each. The fortified antibiotics may be less expensive, but then they are much more cumbersome to prepare too. They are not commercially available. They have limited shelf life. There are issues with storing the drug. There are issues with pH, tonicity, and toxicity of the drug. Fluoroquinolones may be commercially available, their shelf life is not an issue, and it is safe and comparatively less toxic. So with this, there was an important study that was published which tend to study the role of or the efficacy of fluoroquinolones versus the fortified antibiotics, and it was found that they are very similar to each other. But then having said that, over a period of a decade or more, the problem of drug resistance or antibiotic resistance has risen its head. And researchers have found that the number or the percentage of bugs which are susceptible to the newer generation fluoroquinolones are on the rise, and they have consistently progressed over the last decade. So a study which was done in the US has found that the ciprofloxacin resistant organisms are also more often than not resistant to gatifloxacin and moxifloxacin. As you can see from the table here, the cipro-resistant Staphylococcus aureus, coagulase negative Staphylococcus, and the Demococcus are almost susceptible in 40, 70 or 40% of cases to gatifloxacin with a slightly better sensitivity to moxi. So when there is a small, well-defined infiltrate, then probably a fluoroquinolone is also a rational choice. Whereas in a larger infiltrate, a fortified cefazolin or a fluoroquinolone or aminoglycoside can also be used. Similarly, the antibiotic needs to be continued for as long as necessary, and then it should be abruptly stopped, and you should not at any point of time taper an antibiotic because it tends to induce resistance. Now, is there a role of corticosteroids in the management of keratitis, or more specifically corneal ulcers? So again, the ophthalmic world is rife with the debate of corticosteroids being proven and effective, and another group which says that well, it's much more ineffective and dangerous. So it has been found in a Cochrane review that there is no actual significance in terms of the best spectacle corrected visual acuity, the healing time, the time to epithelialization, or the scar size in terms of patients who are treated with or without corticosteroids. So, in spite of several available literature, different school of thoughts, the evidence is not sufficient to conclude that corticosteroids have a grossly important role to play in the management of corneal ulcers, and probably they are best avoided. So consider this clinical case of a 37-year-old male who had 21 days history of pain, watering and redness, and on your scraping you have found this is the calcofluor wet mount, calcofluor white mount, and this is the KOH 10% wet mount. So you have found septate filamentous fungus. So obviously this is a case of fungal keratitis, and we have several group of drugs to tackle fungal keratitis, commonly the polines, the azoles, the pyrimidines and the echinocandins. Now, as a group, what does the group feel? What would be the first line topical management that you would prefer for the management of fungal keratitis? Okay, so most of our colleagues would prefer to start with natamycin as the first line management, and some of us would also prefer other antifungal drugs such as fluconazole, amphotericin, voriconazole. So, what is the role of voriconazole? It is not uncommon to see in several meetings or seminars or discussions in the scientific community where there have been several anecdotal or published reports of benefits with newer generation of antifungals such as voriconazole. And also, it's not uncommon for several colleagues to use oral antifungals such as oral itraconazole or oral ketoconazole in the management of fungal keratitis. Now, what does the published body of evidence say about the role of these drugs in the management of fungal keratitis apart from what our perceptions are? So, a recent important study from Arvind Eye Care System, the mycotic ulcer treatment trial, compared the effect of natamycin versus voriconazole for the treatment of fungal keratitis. They did not find any significant benefit of adding voriconazole to the management regimen of fungal keratitis. A recent Cochrane review on the medical intervention for fungal keratitis also failed to find that any study is adequately powered to find a benefit of using voriconazole. In fact, there is no good evidence for most comparison of other antifungal drugs except natamycin and voriconazole. And in summary, when we compare natamycin versus voriconazole in 3 major trials, the percentage of clinical cure, the microbiological cure, and the best predicted visual acuity is similar or better in the arm that was treated with natamycin. So, rather the risk of adverse events with topical voriconazole has been found to be more. So, from this we can overwhelmingly conclude that natamycin is currently the best drug against molds and yeast at this point of time. And contrary to popular belief, voriconazole was found to be inferior, especially against fusarium. Voriconazole use is associated with a higher risk of adverse events. So when we summarize our discussion today over here, there is a science of managing the corneal ulcers, there is the art of making the diagnosis based on a clinical examination. When one does not have microbiology, then it's important to refer to the established WHO guidelines, and one needs to understand the role of fluoroquinolones, the role of corticosteroids, and should be cautious when we are using the newer generation antifungal medications. So with this, I would like to gratefully acknowledge the contribution of colleagues Dr. Prashant Garg and Dr. Praveen Krishna for their help with the slides. and the materials that we are discussing now. And I would like to thank you all, and we'll take some questions before we end the session for me. So I'll be going with the questions, and you can add to them, you can give your feedback. So I think that one of our viewers have asked that whether it is safe to use steroids in treating a corneal ulcer. The evidence is not sufficient, and probably steroids are best avoided in the management of corneal ulcers. Then, okay. So the WHO recommendations for management of corneal ulcers are a set of guidelines which are available for free download on the internet, and one can go through those. One of our viewers have asked, how do you get KOH? Whether it is commercially available, any chemistry laboratory would have pellets of KOH, and you need to prepare a 10% weight by volume preparation in the lab. And it is quite easy to make a 10% preparation using distilled water and pellets of KOH. Commercial natamycin is quite commonly available, so that is one. And can we give systemic steroids? Probably you should avoid steroids in all forms in the management of corneal ulcers. Systemic antibiotic, again, when we give antibiotics topically, the minimum inhibitory concentration of the antibiotics in the ocular tissue is very good. So unless the lesion is much more deeper, say such as an concomitant endophthalmitis, then probably systemic antibiotic is not important. Then is there a role of NSAIDs, both systemic or topical? Very limited role, probably only to manage pain. Collagen cross-linking in bacterial keratitis is a very exciting thing that is happening now. The results are mixed, and I think the verdict is still out. Then is there in the role of povidone iodine? There has been studies where they have used povidone iodine in smaller group of patients under very controlled conditions. The results have been found comparable to antibiotics like natamycin, but that's again not conclusion. How do we best regimen for management of antibiotics? Okay. Subconjunctival injections, again, when you give an hourly antibiotic regimen, then probably it's not important to give subconjunctival injections. Okay. So culture negative is again something which is very difficult to treat, and one need to actually make a decision tree based on whether the ulcer is responding or refractory to treatment. And if it is refractory to treatment, then probably it's a good idea to stop all the antibiotics for a period of 2 to 3 days and then do a re-scraping. And if the patient is responding, then go ahead with the line of treatment till resolution. If the patient is not responding, then a re-scraping is also negative again. Then if the patient is worsening, then probably one needs to look into surgical management. And if it is responding, then one has to treat per etiology. Intrastomal injection of antibiotics, again, there have been anecdotal reports of intrastomal injection, and there is also some benefit, but then there have been papers which have been published recently which say that intrastomal versus topical doesn't really make a difference. Then how do you suspect acanthamoeba before ring infiltrate start? Probably a typical history of injury with mud or injury with soil, contaminated water, chronic ulcer, severe pain, limbitis, surface inflammation is probably some of the giveaways, but then again very difficult to treat. Okay. Okay, carbolization probably not done anymore. Carbolization of a chronic ulcer. Shelf life of fortified medications are typically within a week. Initially, when you, one of our viewers have asked what has a better outcome, hourly or 5 times ointment. Hourly regimen is given for the first 48 hours, followed by every 2 hourly until resolution. And then you have to abruptly stop it. Combination of antibiotics with antifungals are always best avoided. In fact, unless you have positive microbiology, one should not or preferably do not use antiparasitic or antifungal drugs, and they are not to be used in combination. Intrastromal administration of amphotericin B. Probably it's a very toxic drug. Some authorities believe that it has some benefit, but probably it's probably not recommended. When do we consider corneal transplant as a viable treatment option? Corneal transplant is typically done in a condition where there is a refractory ulcer which is chronic and there is medical failure and it is progressing or worsening. It is threatening to involve the limbus or it is tending to perforate the cornea. So in these conditions where it would be good to do a therapeutic penetrating keratoplasty, send the tissue partly for histopathology and partly for microbiology and await a response based on the diagnosis that you have. Perforations can be treated with tissue adhesives, and in case of large perforations of more than 2 millimeters, then it would be recommended to go ahead for a patch graft or a full thickness penetrating keratoplasty. So whenever you have a perforation, then probably it is better to refer to a tertiary setup and then do a treatment based on the size of the perforation and the severity. Amniotic membrane has been used in the treatment of ulcers, but amniotic membrane in the setting of inflammation can melt away quickly and may not provide much tectonic support. Systemic antibiotics, as we discussed earlier, has limited role in management of corneal ulcers. And those systemic antifungals that are used in the treatment of fungal keratitis, in addition to topical antifungal medications, have been found not to be useful, meaning that the recent studies that are published have not found any advantage of using oral antifungals in addition to topical antifungals for the management of fungal keratitis. Okay, in LASIK and PRK, how should one treat or suspect corneal infection? This is going to be quite a challenge because one needs to rule out whether it is inflammation such as the interstitial keratitis versus or lamellar keratitis versus something which is of a infectious etiology. If the disease appears to be progressing fast with cellularity or reaction and then some reaction in the anterior chamber, then it's probably important to do a scraping and rule out an infection before it tends to progress fast to involve the vision. NSAIDs probably have very limited role in the management. Herpetic ulcers and deciform keratitis needs to be treated with antivirals and and also corticosteroids. And one also needs to look into the head study guideline in the management of viral keratitis. Bandage contact lenses and patching again has very limited role in the management of corneal ulcers. So probably best avoided. After therapeutic keratoplasty, we should, how long should we continue antifungal treatment? So typically the antifungal regimen needs to be continued for at least 2 weeks after therapeutic keratoplasty for fungal keratitis, following which if there is no evidence of residual or recurrence, then you should start corticosteroids. There is no role of vitamin C or cryotherapy. Adenoviral keratitis is often self-limiting and that needs to be treated with topical lubricants alone. Any ulcer which is resistant to all treatment and it is also worsening and threatening to perforate, then they are best managed with a therapeutic keratoplasty. Indiscriminate use of drugs can cause thinning of the cornea. They can cause a melting, drug toxicity. So sometimes it is important to review the regimen and see whether you are using a rational regimen and whether there is not a drug toxicity due to over frequent or frequent drug use. So yes, all antibiotics and antifungals when they are used excessively can cause a medicamentosa or a drug toxicity which can cause thinning and worsening of the ocular condition. Prevention, again, these are, one has to go for oral acyclovir for prevention of recurrent herpetic keratitis or disciform keratitis. So there are well-defined guidelines for the management of herpetic keratitis. One should go through the HEADS trial and its conclusions. Debridement, one of our viewers have asked that, is there a role of debridement in corneal ulcers? This is an interesting question. Actually, debridement not only decreases the load of the, it is important in a fungal keratitis. It's important because it decreases the load of the fungus and it also facilitates penetration of the drug into the corneal stroma. So it's important to debride them. Lubricants have limited role in corneal ulcer. Murren's ulcer best managed by first ruling out whether it is a peripheral ulcerative keratitis due to any collagen vascular disease or any other disease. Murren's ulcer is a diagnosis of exclusion. So once you have excluded all the other causes, then treat it by conjunctival resection, tissue adhesive, and a bandage contact lens with steroids and lubricants. Tarsorrhaphy again depends on exposure, whether there is a whether there is a exposure keratopathy. So there maybe probably one can do a tars. Amniotic membrane transplantation has been tried in ulcers, but it has a limited role. So as I answered earlier, tarsorrhaphic value would be good in either lagophthalmus or exposure keratitis or neurotrophic ulcers. It definitely helps in the treatment of neurotrophic keratitis. Anti-acanthamoeba management is best done by anti-parasitic medications like chlorhexidine. And before one starts anti-parasitic regimen, there should be a direct evidence of the organism in the smear or in the non-nutrient agar. A corneal transplant is the standard management for refractory ulcers, and there is definitely a risk of endophthalmitis for any surgical option that we take on the eye, including corneal ulcers. Cross-linking for herpetic keratitis, well, cross-linking is still a newer modality, and it is, as I said earlier some time back, there is the opinion is again out there.